Good afternoon, everybody.
Good afternoon.
Hi. I'm going to mute while I'm sneaking a quick lunch at the beginning. I hope this isn't too rude. I'm here though.
No problem. Welcome to the additional people who are joining now. I suspect that a lot of people are going to be just starting to join now that it's hit 1:30, so I'm going to give it 2 minutes before we get started. All right. Others may continue to join as we get started, but that's all right. The way I've got the agenda structured, the first 3 or 4 slides that I have are just making sure everybody has a level understanding of the topic we're going to dive into. And so I'm going to go ahead and get started with that. Welcome to the 3rd session of the Social Determinants of Health Healthcare Provider Expert Working Group. We appreciate you joining. We're excited to get your feedback. What we're going to be going through is I'm setting the stage, and then we're going to dive right into prompting questions to stimulate conversation. But regardless of the agenda, there is no time that it's inappropriate to ask questions, no time that you, if you have something to add, go ahead and do so. And we'll move on from that, and then we'll talk about what we're going to be working on in the next session. So today what we're talking about is Z codes and social diagnosis or social diagnoses. And so let's talk about what Z codes are. They are a subset of ICD-10 codes between Z00 and Z99 that are used for reporting of factors influencing health status and contact with health services. And then there's a specific range within the overarching Z codes that are Z55 to Z65 that are specifically used to document social determinants of health data. So today we're going to be talking about when it's appropriate to use Z codes, how is it appropriate to use Z codes, who's appropriate to use Z codes, and I'm going to try my very best to not try to inject my understanding now, but try to prompt questions for you all to share your thoughts on the matter. These are the Gravity Project recognized domains that the Z codes are going to apply to. These are probably not unfamiliar to this group, but just thought I would review that there are a set boundary of domains that we're looking at here. And on the Gravity Project, which is what we're aligning with largely, there's within each domain, they're going through and codifying different things. They're codifying the tools, they're codifying the questions the tools are asking, they're codifying the answers, but they're also identifying the needs, they're identifying the diagnoses that can be made as a result of those things, or common diagnoses that would map from those types of questions. But there may be a risk with that mapping because I'm trying not to inject my opinions, but I want to just draw a line that there's definitely room for conversation on when is it appropriate that if a person needs to make a diagnosis, or if because we've got these symptoms, a diagnosis can be automatically derived. So that's the discussion premise for today. And I'm going to jump into some questions. Oh, I see Dr. Klinkman, you have your hand up. I'm sorry.
Yeah, I started a brief chat just because I wanted to make sure that everybody was sort of together with understanding where we're starting from. And it probably would be good to spend a second or two talking about the Gravity Project. For those that didn't get the benefit of the times we've explained it before. The Gravity Project is a national collaborative with volunteer effort coordinated by a combination of healthcare and technical expert groups to build consensus about the information that we're using to record and manage social care. So the Gravity Project's tasks are to create taxonomy or terminology so that we're consistent in how we talk about social care issues, to figure out standards for sharing and transmitting that information from one place to another. And that work's entering, I think, its fourth year. It is systematically using some expert advice and then a balloting process like for other national standards to say, these are the things that we think are essential about these social care concepts to transmit. So what Mike showed you were the domains, the social care domains that the Gravity Project has taken on for that standardization. What we're not showing at this point is the work behind the scenes to figure out technical standards for how to exchange them across health information platforms and even between medical providers and other providers. We're going to focus mostly today on just what Gravity has built and then had approved as standard terms to connect people around social care, and ways that providers feel comfortable, uncomfortable, want to, don't want to, would appreciate, not appreciate using them, because we really need your advice on that. So that's just an orientation. So for those that want to hear more, just put stuff in the chart. I'll try to answer it as we go so I don't disrupt Mike much more.
Awesome. Thank you very much. So the questions I have today are to stimulate conversation. If we go off topic, that is totally okay. But we'll use the questions to get us rolling. So scenario one, and I've started with specifically a healthcare provider, and I'm going to tell you in advance, we're going to, for the first three scenarios, we're going to incrementally move further and further from a healthcare provider making the decision and talk about where is an appropriate line. So scenario one is an individual has had some sort of encounter with a healthcare provider and has talked with them. They listened to these symptoms and found that there was a water supply problem. So they made a diagnosis of Z58.6, which is inadequate drinking water supply. Is this an appropriate scenario using Z code diagnosis codes? Don't everybody jump at once.
Another way to ask this is, for those of you in the audience that are providers, would you ever make that diagnosis when you had this conversation with a patient? And so Roseanne says, I don't think so. Okay. Erica.
I think it requires more information, right? Just like with
Yeah.
any diagnosis code, we need to understand if it's an actual access issue or a misunderstanding about an access opportunity. So to give to list it as a symptom is one thing, to give it a diagnosis is entirely another.
So in this scenario, it's the what I was trying to get at is that there's a healthcare provider whom is having the conversation to get the right context and is making that diagnosis. And I was hoping this one was going to be an easy yes, that the audience is going to say, yes, that.
What you're learning, Mike, is nothing's easy in primary care.
That they're screening and making the diagnosis simultaneously. Are you going for? Yeah, but
yeah, I hear. I think that we're gun shy to make diagnoses. We've been trained against it in making a formal, even as a Z code. Is that what you're saying, Diane and Roseanne? Like,
right, where's the line? Right. When do you have enough information?
right. I think
comments,
it's an
everybody.
operational definition, probably, unfortunately.
Okay,
When did the questions get easier, though?
We're going to make them harder.
So that alone is good feedback that we can take a note that we should probably make some sort of or maybe not we need to find a definition there of making a diagnosis.
A glossary.
Yeah.
for
There
providers.
is such a thing in the ICD and in any of the guides that you can find even for free online. For those who really want to get in the weeds when they're seeing patients or when they're thinking about this, there are definitions, inclusion criteria, exclusion criteria for when you can make that diagnosis. The practical point here is when we're in the middle of patient care, I'm not spending a lot of time looking up online ICD diagnostic criteria.
Especially if I've already met the billing protocol for that visit and I have
Yep.
somebody, and it means it's going to take away from my doing the homework to get that person access to care. So we need to create a scenario where it becomes really user friendly and evident with an operational definition, instead of people having to look it up and then potentially bundling things for people.
I totally agree with the bundling. You know, we've done social determinants of health and kind of lumped everything into 10 questions in most of our practices. And so that when the Z codes came out, it was very overwhelming to kind of figure out how they fit into the processes that we've worked really hard on over the last few years. It shifted a lot of work to providers when we've been trying to keep a lot of that social determinants of health off the backs of providers. And so understanding how that could be lumped, and then is there ways there can be documentation and using staff to the top of their license versus having it to be all provider driven for the social terms of health would be key areas of focus for me.
Or depending on how somebody built their EMR around the SDOH 10 question resource, if it could a no or a yes answer respectively trigger through you know, in my practice it'd be like a smart form entry code, but everybody's EMR is different, but potentially trigger a rule to assign that diagnosis that would still be appropriate because the provider created the rule, for instance.
Erica, hold that point. We're going to come back to it. That is a critical thing in how we're trying to figure this out. And there's a lot of good and some potential bad in that. So, yeah. So hold that thought. We'll come back to that. Actually, Mike and I have probably figured out that that's something that we should talk about here. So good.
I do like the differentiation, I do not, scenario 2 jumps a step further, but I'm going to create a scenario 1.5 just to kind of what was described already, where in a healthcare setting, somebody has talked with a person, but it wasn't necessarily a doctor. It was some sort of healthcare professional and versus a doctor making a diagnosis. Those are two different scenarios that we should probably break apart. But I'll jump to scenario 2 because we kind of already talked about that, but interesting differentiation that I wasn't even thinking about when I made this. So scenario 2, an individual talks with a social service professional who listens and has this conversation, making sure they understand the problem, and they make a diagnosis of Z58.6. How do we feel about this scenario? Feedback, thoughts?
So Jenny put something in the chat that I'll raise up for everybody to react to. Yeah, and Melissa, same thing. It's not appropriate. Who is the professional? Are they licensed to diagnose? Is this their call? Yeah, Amy, got your hand up?
Yeah, I was going to say, I think that runs into some legal issues about the use of a medical quote unquote diagnosis, because Z codes are part of ICD-10. There may be some legal issues that run into non-medical people per se using a medical diagnosis. It's almost like nurses using non-nursing diagnoses. There's areas that they can and can't. So if the social service professional is not a medical provider, using a medical diagnosis might be a legal issue.
What if we did it a different way? What if we had people who were in social care circumstances or organizations not assign a diagnostic code, but just assign a term for what it is that they've learned about this person? They have a problem with drinking water. That's just a term. That's just a fact, right? When they talk about it, it doesn't require a medical license to hear somebody tell you they don't have any drinking water, or they don't have a well, or they don't have a source of reliable drinking water in their home. Would that change your thinking about this at all?
How would you codify it, Mike? Is
Well,
free form or?
There's lots of ways to do it, but the codes are hidden. It still could be coded because there's no clear rule that requires a licensed physician to assign an ICD term. There could be different codes behind these terms that apply to each person's care domain that you map, which is what we have done by and large with social determinants of health screening codes. So we're trying to figure out, the whole idea here is learning how to communicate across sectors of care and trying to figure out how to make those communications as clear as we can. How would the group? Yeah.
Well, I have a comment here. There are really good coders in the real world that many of us rely on and have driven a lot of the work that we're doing. And I agree with Jenny's comment about the thought processes the doc is diagnosing, and we add the advanced practice providers to that category. But I think sometimes we overstep our boundaries. We have certified coders who really drive a lot of the work that we're doing. And do we have any certified coders that are also compliance officers that could chime in this discussion today? Because they really need to be part of the discussion as well.
Nice point.
And if we're looking at how best to address some of these comments that might be made in free text, this is where the care teams are so important when they do their chart reviews with the physicians, because at that point in time, they could really introduce the fact that there is a Z code that has been identified, and could the physician actually include that in the diagnosis list, which is why having that care team is so crucial to the work that we've been doing over the years. But again, provider engagement is crucial, but I would want to see a coder be attached to this committee to get real feedback from individuals who live in the coding world.
That is
So
great.
I can answer some of that comment just before Mike jumps back in. We've been through many iterations of those comments and those feedback as part of the Gravity vetting process. So some of that we can bring back to this group as needed. I agree that it's nice to have somebody local and engaged to work through it. What you have seen and what you can see if you go to the Gravity Project website or you look at the National Center for Health Statistics new Z code list, the ones that they've approved over the past couple of years, those have been very carefully vetted and defined so that the amount of subject matter expertise that a coder would need to assign the code correctly has been brought to its minimum, I think, about as well as we can vet them. We vetted them. That doesn't mean that people can interpret them well yet, but it is not nearly as difficult as trying to nuance the 37 different types of non-systolic heart failure. So we're actually in fairly good shape with some of this. Mike, I'm sorry I jumped on you there.
You're all right. I said exactly what I was going to say. I said that was great feedback. Yeah. More thoughts on this one before we move on to scenario 3? All right. For those who have joined recently, we're going through scenarios having to do with Z codes and social diagnosis, and some of these are intentionally loaded just to get responses and reactions and stimulate conversation. So scenario 3 is an individual has completed a screening tool of some sort, and through that screening tool, it surfaces that they have this water supply need, and a diagnosis is automatically mapped from their answer to Z58.6. So the questions then is this an appropriate scenario that we're automatically mapping based on the patient's answers to a questionnaire? And is it generally appropriate to do that? And we're talking specifically about social diagnoses, not getting into anything outside of Z55 to Z65.
No brave
I
souls
love-
want to touch this one.
I love that Dr. Klinkman was literally covering his mouth.
So Erica, this is back at your question from earlier. What do y'all think?
Some of us are already doing this at Henry Ford. We're linking from screening directly to dropping a code. We don't have an assessment that would intervene on that.
So talk about the reasons why you're doing it and why you think it's the right approach for you guys. That'd be a good thing to raise for the group.
We are doing it because we wanted to start practicing. I mean, whether that's good or bad, we really wanted to configure our Epic structure so that we would have the ability to be able to connect from screening, which is what our SDOH data collection platform is. And this does not include our Jackson work. This is only in our Southeast Michigan market area. If we had a deeper assessment or we had something that could ask questions on a more ordinal or scaled variable approach. I think that would be more rigorous and would probably be closer to an assessment. It would make the information that we're getting from patients more rigorous. So I don't think that these are either or. I think every organization like ours who's only doing yes/no screening right now, it's imperfect. But if we have information that we can act on, it seems appropriate to drop that code as part of the overall approach to capturing data and also intervening on these SDOH barriers. But we shouldn't stop there. So I think it can be both and in the intermediate. If we got complacent with this and said just screening yes/no, and that yes, we're not quite sure exactly what it means, but that's all we're going to do, and we're going to try to throw the kitchen sink at a patient who's, who has that water or has another sort of insecurity, we would find pretty quickly that the data wouldn't in the long term bear out a ton of investment on just taking action on yes/no questions. But if it's part of an intermediate step, it may be appropriate.
So I have a question. Can anyone tell me how CMS has identified the appropriateness of collecting the SDOH and who in the person's care team can collect that? Because I always rely on CMS being the driver for what is legal and not legal. Dr. Klinkman, maybe you can answer that. Has CMS gone ahead and identified whether any person can actually collect SDOH data documented in the patient's chart, or are we still restricted on ensuring that a licensed healthcare professional, MD, DO, et cetera, is the one who should be identifying that code with the coder?
Yeah, they have not, as far as I know, from the Gravity Project work groups, CMS has not made any statements about changing their rule to be more liberal about the use of the social care codes or the social determinant codes. So the standard is still that in an electronic medical record, it's the clinicians who have the responsibility for maintaining the diagnoses.
So can I just push that a little further for those of you that are recent recipients of the REACH ACO acknowledgement? What have you found to be appropriate as appropriate for the REACH ACO?
Might need to table that one because I'm not sure that anybody on the call is part of that group. What I can tell you is that the intent of the Gravity work and other collaboratives work is to reduce the restrictions on who can call out social problems, so that in an ideal world, if a Z code was a good way to capture that code on the medical side, that would be also translatable to a community information exchange and be used as the problem for which a request for interventions could be made. That's the intent. And we don't know what the regulatory environment's going to do. So far, both CMS and ONC have been sort of waiting to see how the ecosystem develops before they make any regulations about passage of codes back and forth. But I want to come back to what I saw Amy and Melissa write in the chat here, because I think it was a way to try to get to answers around, is it okay, as Alex kind of was pointing out, to go directly from a screening result to a problem, a diagnosis? And I think that the counterpoint, I think Amy and Melissa, if either of you want to, unmute and talk about why you said what you said, I think that's a pretty important point to bring out in the discussion.
From a community health perspective, because I'm a community health worker, I think that it simply leaves too much room to not address the issue at hand or the disparity at hand, right? So, we're asking the question or they're answering the question. Now, what happens to that data beside it being a data point, right? We need to be able to actually address the issue. So there needs to be a resource attached to it or some kind of counseling that then takes place. How do we actually help the patient in that situation? And I think it just leaves too much room for that part of the pie to fall through the cracks.
And a question for Alex before Mike shows walks through what's on the slide. Alex, did you do this for some determinants and some domains, but not others? Did you make any selections, or did you just start off with using it for everything that you were screening?
No, we only do it for those SDOH variables which we can intervene on. So this is tied to work that we're already connected in either directly through our United Way partnership to our community partners, or that are on the sort of key list of SDOH domains that our case managers are able to make manual referrals for.
Okay, all right.
Isn't this the tool that CMS has put out? So step one actually says that
Yeah,
any member of the care team can collect SDOH data.
Yeah, I actually remembered this when you asked what has CMS said, and so I went and found it real quick, and I'm showing it. But yeah, this is the only thing I've seen of what CMS has said, and it says step one, any member of a person's care team can collect the data, and then step three, it says map SDOH data to Z codes. So as far as legality is concerned, it looks like CMS is directing that's okay.
Well, and this is also something AHA is pretty widely promulgated as well. This is maybe worth a sidetrack. So at our last Gravity Project Technical Advisory Committee meeting, this issue came up around, is it okay to automatically go from a screening result to a diagnostic statement without any kind of an assessment? And we had a long conversation with some of the Blue Cross Blue Shield analytics team, national analytics team, who said, we're working on algorithms to do that now, going from some of the more commonly used SDOH screening instruments like the Prepare tool, which has its own set of responses for domains, and a Z code diagnosis based upon data and outcomes that they have pulled together at various places around the country. They haven't shared that data yet, and their position right now is that it may be feasible and technically possible to do that for some domains. The best example is for food insecurity, because the definition of food insecurity is very close to the specific question in many of the screening tools. But for other domains, especially for the housing domain, it's too complicated to be able to assign a diagnostic code without doing some assessment. And we don't know how that's going to roll out. That's going to be a topic of conversation over the next few Gravity Project technical meetings to see whether or not step 1 to step 3 of this Z code guide that Mike's displaying is going to give us valid information. We saw in SIM, at least in one of the sites in SIM, that step 1 to step 3, we lost over half of the positive respondents to a screening question when we tried to vet their answers to see whether they had a problem that was current and for which they needed help. So that statistic is always in our minds when we're trying to think about these automatic translations of screening results to problem statements. And I think that gets back to what Amy and Erica were sort of getting at earlier, which is there needs to be some human intelligence in the middle of all this. And yeah, Alex, yeah, just in your chat term, the same thing. Would you as providers feel comfortable following this 5-step plan? Beth would.
So Dr. Klinkman, I guess I've pulled out an article that Andis Robensniks wrote for the American Medical Association for JAMA, and they interviewed Dr. Andre, who's Michigan Medicine's CMO for billing compliance. And the comment is always made that those Z codes are health factors versus true clinical interpretations or a clinical diagnosis. So I'm struggling. We're all struggling right now because we're trying to figure out how health factors really fit into the actual ICD-10s, which are diagnoses. And it's a great article if folks have not seen it, because he's actually, this writer is actually linking health factors to clinical diagnoses. I don't know if anyone's seen that, but it's just a great opportunity to figure out how those factors fit into the actual clinical diagnosis rather than it being a true clinical diagnosis. Do you
Yes.
know where I'm coming from?
Absolutely. Can you, if you want to pop that in, if there's a link you can pop into the chat, I think that would be good for everybody to read, because we're not going to solve this problem in this session. So I'll make another old fart family dot comment here, and for what it's worth, we see some of the same problems with other, I guess, interfaces between primary care, community care, and sort of more specialty level medical care. And we see it in health, in behavioral health symptoms that don't rise to the level of a behavioral health diagnosis. So elsewhere in ICD are the feeling codes, the R codes, R45 to something, R43 to something, which is feeling sad, feeling unhappy, feeling stressed, which are not the same as hard and fast F code mental health diagnoses. And we have the same tension when we're trying to figure out when to assign those diagnoses or those terms to describe a problem that we don't have an answer for yet. So I don't see that there's a whole lot of difference between the R codes for mental health symptoms and the Z codes for social problems, or social problems that are emerging at a level that they need to be addressed or logged or monitored in a medical record. But we have not resolved these conversations at a national level. I think there are people who say that the Z codes are kind of worthless, should be sent out of ICD entirely, put into their own corresponding structure that is not legitimized with an ICD term. There are opinions all over the map. And what we're trying to figure out for Michigan, and what Mike's trying to guide us through here, is can we figure out a way collectively that we're going to use these codes consistently in Michigan as we start to roll this stuff out and start to share this stuff more broadly. So, and if your comments are spot on, I just don't think that there is not an answer for those things yet. And maybe we are the ones that will be making those answers up, because as far as I know, this kind of a forum is the only place where we get a chance to talk about these things.
Right. Thank you for that.
So Jenny, do you want to comment on what you put in the chat too? I think that's another important point, and I'm not sure how we're going to address that either, but it's a good issue to raise. Okay, well, I'll take it on I'll take it on behalf of Jenny. When a patient is getting an EOB, we have occasionally in my practice had comments or complaints from people when we put something that the patient might not appreciate on their EOB. For example, recording an existing diagnosis of depression, it shows up as part of the list that gets spilled out at the end of the visit. And it creates disharmony in the person who sees it. And if we're going to call out social problems and have them show up in an EOB statement or in an after visit summary, are we prepared to deal with those things? Oh, Jenny, good. Come on in.
You said it way better than I could. Thank you. Yes, that was the thought bubble that I had. I remember it. Actually, it's back in pediatrics and some of the early onset diagnoses we were using with children and family around nutrition and things like that. So it's just something that struck me as I was listening. I'm trying to put any thought that hits me that I have a connection to in the chat. Are they sequestered? What is that part of the, oh boy, okay.
They're not. But Alex, you want to describe what you guys do then?
Yep, and I just threw it in the chat too. Our Z codes are hidden from the EOB, so patients would not see that the Z code was dropped when we do them, but the AVS is separate. And so the provider in their conversation, if any information is relevant, the providers can go through a list and click on various resources that'll come through the AVS. Ours is still a little different even than from what could be done out of the box. If you're an Epic shop and you're using Compass Rose, there's a lot more functionality built into it. We aren't using Compass Rose yet, fingers crossed. For now, with our work with United Way, we actually bypass a lot of the AVS stuff because we haven't configured quite how to get the United Way social navigator information into our AVS. So that's a little bit of a gap, but there is some hard information we can put in, and a lot of that's actually pulled from Elsevier in our inpatient department. But that's AVS separate. Patients would not see in the EOB that a Z code was dropped.
Okay.
Are you going to submit it to the payer though? And how would the payer sequester it?
I don't know that information. I just know we went through about a 1.5 month long process with our coding team. And we were able to test this with claims so that the patients don't get, it's especially important sensitively, right? You don't want information that's going to the home of a patient reveal domestic violence or safety. So there is a way to do it. What the payers, so from the provider side, I know they don't see it. My understanding is that the payers have a way to handle it too, but that's a question better answered by someone on the payer side.
So Mike, note to us for this is that we probably want to talk to payers about their place in this transfer and sequestration scheme, because I know that we've had issues internally at Michigan Medicine with our billers sending out truncated lists of diagnostic codes because we might have 10 or 12, sometimes more, they get clicked off during visits. And the transmission of all that stuff is something that historically we have truncated, and we don't know what gets truncated. We don't know if billers have internal rules that are setting about taking off the Z codes because they're not HCC codes, so we don't get paid more for them. There's just a whole lot of stuff in the middle of this that we don't know happens. And I don't know if any of you have experience with your organization's billing or any personal experience with codes being taken off your diagnostic lists from a visit, and whether that is a worry for you here. Stacy, you want to talk about seeing that or what that was?
No, I mean, I would agree with what you just said, that we hit so many on our charts that the billers at some point are also removing them, unsure sometimes what they're removing. Like they're going to leave the ones on there that bring the money in, and they don't always understand what the CPT codes are and some of the other codes. And so, yeah, if they hit so many numbers, like they don't all get billed out on the claim. So I could see that being a big problem.
Okay. Oh, this is so simple.
I can add a little bit for Michigan Medicine. I'm on the HIE team, so we send all the messaging to MiHIN. So I know for all the messages we send to MiHIN, we remove any non-ICD-10 codes.
Okay.
So we only send ICD-10 coded data to MiHIN. We, however, do not do the billing. That's all on my chart.
Okay.
And I don't have anything to do with that, so I don't know what they do.
So Harriet, this is a great follow-up. Thanks for volunteering this. Do you ever take anything off, or is there a limit to what you send on to MiHIN?
No, the only thing we do is take off anything that is not ICD-10 encoded.
Okay. So if I had 19 ICD codes for my visit, which is no exaggeration for some of them.
Yeah, it's not.
You send them all on?
Yes, if they're ICD-10, we do.
Okay, good. Thanks. That's one.
Yeah, I've seen them with like 50. So yeah. No, only if it's not ICD-10 encoded.
Good. Okay. Other questions here? Jenny, huge worry? Yeah. Okay. So Mike, I'm going to hand it back to you. Sorry we got so sidetracked here, but it was a great discussion and really helpful.
That's the whole intent of this. That was not a sorry scenario. That's We're trying to surface as an ecosystem, as Michigan, what do we want to try to work on? What are we comfortable with? What do we want to implement? So the next question is, should MiHIN care? Should we have a role in advocating for how Z codes are used, or should we just focus on collecting, distributing, and reporting?
Are those two things different?
I mean, if we say we want to collect Z codes, should we care if it was a person that made the diagnosis or if it was automatically mapped, or should we just ask for Z codes when it's a scenario to ask for Z codes?
How would you know the difference?
But we wouldn't. But do we have a role in advocating? Is all I'm asking. And if the answer is no, that's less work on me.
And I guess hidden in Mike's question is a really subtle and difficult question, which is appropriate use. Because that will take some work, because I imagine there are probably 20 different ideas in this group, in this chat room about appropriate use of Z codes. But one of the issues that MiHIN will try to address is, are we just piping and plumbing, taking what you guys send and just moving it around, whether it's of high quality or not, as long as it meets our transmission criteria, which we can do and will save us a lot of gray hair. Or collectively, should we try to evolve some shared understanding about how to best use Z codes so that they're meaningful information for everyone, I guess. That's kind of how I would parse this. And if we agree that we should have a role in trying to figure out what that quality control and shared purpose for moving this information is, how much work will it take for us to get to that point? And Amy, I think, yeah, looking at the chat, yeah, I think MiHIN does advocate for coding accuracy in areas. Sometimes to better impact, sometimes to worse impact, sometimes we have leverage, sometimes we don't have leverage, but we try to make sure that the data that we exchange is valid and useful, which is our fig leaf to look at this appropriate use of Z codes at this moment.
So I think that it's appropriate to have criteria, but I'm not certain when it comes to sort of, I think that there's like a fine line between criteria and too many rules, I guess. That's where I sort of am considering on this. Like, if you don't have good data because everybody's using the codes in a different way, and it's useless. I mean, why even collect it? But I guess, like, if the outcome, if like the end result of the data isn't something that we can use, then we have to put in, then it makes sense for MiHIN to advocate and be the ringleader for having enough structure that the data that we're collecting, that we understand it.
And let me just echo that and just say to one more point on top of that. I think MiHIN plays an important role as a convening body to include payers and others who are involved in setting and creating the norms around this work. I mean, MiHIN's role is very clearly in the latter three areas, but I think the Z codes very clearly directly stem from that. And there will be more things that we'll discover as this work matures. But currently, there isn't really a body or a platform for bringing some of these folks together to discuss the norms around this that MiHIN should have or could have a convening stake in.
Others?
I think it's like the old adage, right? To whom much is given, much is expected. And I think I agree that there is a fine line between, too much oversight. I guess I would just impose kind of that caring lens, particularly over the movement of this data. It's a little different than just a hypertension diagnosis. So anytime we can convene the right stakeholders to challenge, to be more patient-centered and caring in the movement of important information, I think is helpful.
So yeah, Jenny, let me just echo that, because this is pre-publication data sharing from a project we did in Michigan, looking at patients and their impressions about sharing this information. And we wound up with a pretty big split among the people that we did interviews on for whether they felt like this data was okay for physicians and practices to ask about. And when we explored why they had opinions about this, some of it was I guess the lack of caring and follow through and a need to not simply expose weaknesses or problems in yet another forum if there wasn't going to be follow through and thoughtfulness about where those bits of information could be protected. We're teasing out what we got from, like, I don't know, 70, 80 individual person interviews. And people have thought about this when you ask them, but they haven't been able to express opinions. And this is a really hard issue. And so I guess, I'll just echo what both you and Alicia said, that trying to work this through or figure out if a small group can kind of take some of this on and figure out some rough rules of thumb to start with would be a nice place for us to go, maybe. Because back to Adam's example, you don't want to see an explanation of benefits that you're in a domestic violence shelter. And you don't want to see in a medical problem list for somebody else to look at all of the social problems you have to say, oh man, what's the problem here? And get some prejudicial first glimpse at a human being because you're looking at their problem list. So this is new turf for everybody. And does the group in general feel that this is worth doing? Erica, you got your hand up, I can see. So yeah.
Well, just not everything that's a diagnosis ends up, like we've talked about in the chat box, as a problem list. So you have to designate that it's a chronic or ongoing issue for it to be assigned, just like somebody who has sinusitis. It doesn't make it a permanent problem, but it might mean that you discuss with them some supportive care measures and some alert symptoms and some things we can do to help them feel better. I think that we need to consider that when we're providing support in the use of Z codes, that would be true of these too. I don't remember the person's name. I remember reading it earlier in the chat though, and I'm sorry, I could scroll up, but somebody specifically talked about how just because it's a diagnosis doesn't mean it's a long-term problem. And here it is. I know I missed it. Anyway, I don't want to waste your time with that, but is there a way that we can help practices recognize that just because we give a Z code doesn't mean it needs to be checked as it's a data collection tool for us to make sure we're educating and resourcing for our care teams to work with, for the state to have an understanding of how we as providers and care teams are allocating our time to these really important factors. That doesn't mean that it would need to end up on a permanent problem list. It may not be a permanent problem. A lot of these are transient issues if we do our job well.
Mm-hmm.
And I'm wondering if that could be a caveat that we could include as a consideration in how people are collecting, distributing, reporting these Z codes.
Good point, and clearly worth noting. Yeah, these are not permanent residents of any problem list if they come up. And that can be one of the rules that we could agree about as part of a common use case for the Z codes in clinical practices.
That doesn't answer people's concerns about it being potentially reported from an insurance perspective or showing up on an EOB, and those are real concerns. There's already such a stigma associated with people allowing us to understand their help needs. We don't want to create more paper trail that may discourage people from their being honest on these questionnaires and conversations. But at least that addresses some of the paper trail from a diagnostic perspective.
Let me ask a question that we've talked about occasionally at Gravity and at MiHIN. And I think I mentioned it at one point in one of the presentations we did in Diane's multi-payer group. Would it be at all appealing to have the Z codes and whatever they grow into contained in a medical record, but not in a problem list, but in their own separate sort of social problem registry where they can come and go as they're active, to be handled in a special way, not the same as all of the other ICD terms that we currently use?
I think it kind of happens like that in Epic right now when we don't use the Z code, where we have like in the social history section, all right, I'm not exactly, it's in the plan of care and there's like a space for social determinants of health and there's like it turns red when the risk score goes up. So it's kind of a notification there. And then we're trying to share the information of what's available by sending it through MiHIN of, what is the current state essentially of our patient population and their needs. And so it kind of avoids that diagnosis, which I don't think happens with significant regularity, at least in our teams at this point, but.
So just to be clear, Alicia, I've seen some of the pop-ups that come. We've got a place in my chart where the results of our Partners in Care social determinant screening goes. And that data is or is not transmitted through with other data to MiHIN at this moment.
It is.
So MiHIN is getting that data, any instance that we have of somebody completing the Partners in Care screen.
Right.
And clinicians have a couple of clicks at the very least to get down to see it when somebody's just coming in for routine care, because it doesn't really blast itself into my face sheet when I'm seeing a patient.
Right.
Okay. So you've got much of what we might envision as a separate way to handle active social issues already embedded in Michigan Medicine's instance of MyChart. Is anybody else in their practice or in their organizations taking a similar approach to kind of get that information available but not formally contained in a problem list? And if not, does that sound like something that would be potentially useful to think about doing, or does it just make no sense?
So I know that there's a couple of other places. I guess I don't know if I'm cutting anyone off, but I know that the health focus registry that some of the independent groups are on also can collect that data separately once it's being entered. I don't know if it's like I know that it has a place to collect it. I guess I should say that there are some registries that have this ability to sort of develop this additional, essentially, registry of social determinants of health.
Okay. Okay, thanks. This is useful. Anybody else comments on this topic before Mike gets back in the saddle here?
Mike, can I just ask if there were a separate social registry that kind of as a collection device, how does that, I'm just thinking about CMS and their use of Z codes for Medicare patients. Is there some way those two worlds could live together, at least for a while, until there's kind of more evolution in this space?
I think so. I haven't thought about it deeply because the idea is we've just been sort of jamming it around and trying to figure out where it makes sense. But I think you could. I think that there are, at the time that a social care issue, from screening to problem for which we're sending a referral, let's just kind of walk it through a process. So I see somebody in my practice, they've got housing insecurity because they're going to be evicted in 2 weeks and they don't have any place to go and they don't have any money to be able to afford any kind of temporary housing. So that's a pretty active issue that we need to address. So I send a referral to our community action agency or Avalon Housing to say, I need some help with Mr. Jones. And in our version of a near future system, and in some of the shires, those referrals for that kind of help could be sent off to the social care provider who's in partnership in the shire for those issues as a referral. And that referral could have, at the moment that it becomes that referral where there's going to be care given for this problem for this person now, we could assign a problem code that would be a Z code that doesn't mean it was a screening issue that we're tracking or paying really close attention to. It means a problem we're actively engaged in fixing now. And at that point, that could become a data element of interest to CMS and Medicare and Medicaid and everybody else beyond just a screening result.
Mm-hmm.
And that's a two-step process that might or might not have assessment built into the middle of it. But at the point where we as a cross-sector care group say, we're dealing with this problem now, thank you, then I think we need to know what it is in a relatively granular way and know what services are being provided to remedy it. And then hopefully get to learn what the outcome would be of having addressed it.
And Mike, to also Jenny raised a important clarification in the chat about not asking providers to look someplace else and yet another separate registry. In your idea, in that context, could it be a function within could this be a function within certified EMRs or EHRs?
Yes.
Yep.
It would take some work, but you could just create rules to route that information when it accompanies a referral in the form of a referral message that would contain that information. Yeah. Okay. So there's a little
Stacy's comment is also helpful because it kind of providing a range of alternatives depending on the flow of work and ability. Yeah.
So Jenny, we hear you loud and clear. I don't want to have to enter one more thing in one more place in my chart anytime soon.
Well, I think it also makes it easier for people who may not be as comfortable or as invested in SDOH as we would like people to be. If they're familiar with Z codes and we create a system for Z codes, then it's not hard for people to figure out. If it's got a Z in front of it, it's part of this. If it doesn't, and it also then destigmatizes the SDOH. It's not that this is a separate registry for people who have unique needs. It's that this is a registry that serves for this kind of billing. That's different.
Mm-hmm. Yeah.
And those aren't diagnoses codes, those are circumstantial codes, right? So then again, it takes it out of this is part of somebody's permanent record. We don't carry your Z0, your wellness visit for Medicare code to every visit thereafter. It is not part of their permanent diagnoses problem list. So it's a rule that primary care teams are already familiar with. They also know that they can't assign things like for your Medicare patients, at least for like labs and other diagnostics to these Z codes. They're familiar with that. They understand this is a working diagnosis, screening diagnoses, those kinds of formats, that it's not a functional diagnosis. And that's a very helpful thing to kind of build on that trend. I'm sure that's why Z codes were facilitated for this format in the first place.
Yeah. Other comments? This is starting to get some traction here, at least in my head.
I just have a comment on, I was thinking about for the patients that don't have the issue per se yet, it's looming. Could that area also act as a to be watched area per se, where someone is talking about, okay, well, I have this particular housing issue, but I'm working on it. I'm not very hopeful, but it could work out, blah, blah, so it's not really at at the official diagnosis point per se. It's a suspected or could occur kind of area.
Yep. It's like a stick-it note, basically. And there was a time when we were trying to figure out how to do what would be the equivalent of, a little tiny yellow stick-it note in our charts for those sorts of issues on patients. This may be a more systematic way to think about it. And it does bring back closer to what payers and provider organizations really feel is a population health use case need for this data, right? It's the people that they want to be worried about. They have to really pay careful attention to. And I'll use the word that people hate to see used here, which is targeting, which is kind of the negative side of this. You find people who've got social problems and you target them for care, which is really a pejorative term in the community at this point. But finding people who you kind of need to keep your heads up about from the medical standpoint is another use of this as a registry, as a loose registry. So yeah, that's a middle ground that may be helpful. I'm not sure that it requires Z codes. This is something that could be accomplished perhaps just with screening results as well. But it's certainly worth a deeper conversation about as our ideas get more clear. It also lends itself to then team care, where it's not the clinician seeing a patient who has to deal with that information at the point of care. It's a team taking on that information as it accumulates over time.
So it's almost like a social risk score.
Well, it's a live social risk score, not an artifact social risk score. Yeah.
Just to stir the pot a little bit, thinking outside of traditional healthcare and EHR, dentistry already has a watch list kind of a thing where, like, we don't need to do anything about this tooth yet, but we noticed the gum line was a little off, so put it on the watch list.
So what I'm taking away from this conversation is we're going to come back to you maybe as we think a little harder about this idea of registries and a list that kind of helps us figure out who's of concern as a separate issue, but related to the whole idea of Z codes. And Z codes are the relationship still between a screening result and a Z code remains to be, I think, correctly fleshed out. I don't think anybody's there yet. So other comments and wrap this up before Mike moves on to yet another question.
I just have one more comment. I think that this will become more and more important as the role of community health workers and their provider status becomes more important, because I do see that teamwork, that element of the care team perhaps taking on the massive amount of assigning Z codes for the work that they would be doing. And so I appreciate you bringing this up and sort of proactively thinking about it. So thank you.
Thank you. All right, so we've kind of already gone into this one. Dr. Klinkman was asking the question differently earlier, but we're trying to come up with questions that surface Z codes and social needs screening in different ways. And so if you're as a healthcare professional provider licensed person, what is your responsibility in handling a positive screening result?
I'll shut up at future meetings. I know I'm talking too much, but I didn't get to attend the last two, so I'm just making up for lost time. I'm faculty at Georgetown University in their master's program for nurse practitioners in family practice, and we teach very explicitly their first clinical semester, the didactic, that do not screen if you don't have a plan to implement in order to address what you screen for. So that means if you don't have the tools, that doesn't mean you ignore it, but you need to refer to somebody to do that additional care in for the screening and so on. So we have no business doing the social determinants of health screening if we don't have an intention or ability to follow through with referrals and resources.
Right, I was thinking, again, as a community health worker, this is where, having a good relationship with one is very important, or coming up with a resource library, something that we've kind of talked about on our side from an SDOH and Z code perspective, is taking the 10 epic questions that we have built in, linking it to a commonly or the commonly used Z code, and then 3 resources that the practice can automatically go to for those particular situations, so that there is an answer, or there is at least something right then and there for the patient.
And Melissa, can we replicate you and have one of you in the Upper Peninsula of Michigan, please, 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 please?
I hear that way too much. So, that's why I advocate for the whole CHW thing. It is, we do an incredible thing, and we are able to provide so much information for the patients. So I cannot speak enough. I am so glad to be sitting on this particular work group, listening to you guys talk about, what your part in this is, because I hear it and I'm like, well, this is what I do. This is what I do. This is what I do. So this absolutely advocates for the need for community health workers, and a partnership, a strong partnership. A separate question that I have on a side note: does the Gravity Project have a crosswalk document that distinguishes between the specific SDOH domains and their commonly used or recognized Z codes?
They do. They've been going by domain and solidifying codification one at a time. Actually, one of my earlier slides was straight from their website, but they have this, that basically when you click on this link on their website, you'll get to a file that'll have all the codifications, including the Z codes.
Oh, perfect. Okay, wonderful. I think that's very helpful too, right? So having that right then and there for practices is great.
Melissa, can you speak a little bit more based on your role to the question that they was posed at the very beginning about a non-provider, I think it was physician, assigning a diagnosis. This tool was based on that crosswalk, developed expressly so any member of the clinical team, especially in your role, but it could really flag our patients who have support needs.
Yes.
I know I don't have the privilege of having a community health worker, but I do have a really astute front desk team, and they recognize when they may not know all the tools and resources that you do, but they do recognize when somebody's waiting for the bus stop instead of driving home, or they recognize when somebody arrives wet without an umbrella instead of being accompanied by their usual caregiver. So those are the things that in our practice trigger a questionnaire being asked again outside of the annual visit. And so I'd be really interested to hear more about what you think about having your assessments connected with these diagnoses that would then be reviewed, like your
Yes.
Like if you see somebody for an appointment, your records are not billable at the same level, but they are shared with the provider, who can then capture more, not only reimbursement, but build on your expertise to establish a different level of care if needed.
Right. So I kind of work together with our care management team, the PO level. So that kind of makes my job and my relationships with the practices a little bit more easy and open, right? I'm actually in there and we're having these discussions. Right now, a big part of what I'm doing is providing for practices an SDOH workflow example, right? So how they can implement giving those questionnaires within the appointment. So annual physicals, right? So yearly, those patients are always getting an SDOH survey. From there, those cues that the receptionists are getting at the front end, or even the doctor is getting, they can send referrals straight to me to then go through. And I do that SDOH survey myself. Absolutely. I still stick to the idea that the doc is the one who is entering in that Z code, right? I always go back to that. I just think that's the best way to go, just from what I've read and everything that I've seen. As far as the documentation is concerned, it's got to come from that end. But I do think that at this point with actually giving the SDOH survey, I am all for, if I get the vibe from someone that I'm on the phone with that needs a resource for one thing, if I get that vibe, I give the full SDOH survey and then I report back to my doc. So I think it's really important that we are establishing more partnerships with you know, whether it be a community health worker, a social worker, something like that, in order for those things to kind of be answered.
Thank you.
Other comments?
I have one more. I think that it's incredibly important to have a team who can react to these things appropriately. But I think that it's interesting. I think one of the other things that we're trying to work on is how do we engage the people who are designing the care plan, the providers, in using the knowledge to develop an appropriate care plan, or one that can be followed by the patient. Because I think it's one thing to make sure that the patient has the correct referrals and all of those pieces. But it's also really important that the provider make sure that they're, you know, not placing expectations upon a patient that person won't be able to do. And so I think there's a lot of things to be done. And the first thing really is to get the screening done and the reactions to the screening, but then sort of how do you incorporate that into daily life moving forward?
Yeah, so I'm going to wrap up these last three comments because I think that they fit together really well. Thanks, Alicia and other folks. It feels to me like unstated in the conversation is that two things are really important here. Ongoing communication. For example, if a care plan isn't going well or doesn't seem to be constructed or is lagging, but also bi-directional information, because all community health workers won't be working on or in the structure of a clinical practice on the healthcare side. There are going to be lots of community health workers working for community service organizations, for some payers who have now invested in community health workers as sort of an effector arm tool to do this kind of work. So it can help us greatly as clinicians if those community health workers who are in the community, in the field, screening our patients like we just heard Melissa talking about, can share their information with us bi-directionally instead of it having to come from the medical side only as a starting point. So that's really critical and why we're trying to make sure that we can build these simple communication structures in place and we have a way to use right terms so we know what we're talking about. Second thing here that I thought was really important is that there needs to be a way to understand who's driving the care plan. And that is independent of a Z code itself. But if you have a number of people, both on the healthcare and community sides, trying to work with Mr. Jones, part of what MiHIN has predicted, wanted to do, tried to build is building out the active care relationship service so that we know the clinicians and the social care clinicians who are going to be active with a person in solving this problem that we've now identified and are labeling, but also who's kind of got the baton as the key person who's responsible for making this stuff go so things don't slip through the cracks. And we will be coming back to you all as our thinking about how to expand the active care relationship service that MiHIN currently offers to cover social care better. As those plans kind of get going, we'll be coming back to you to help us figure out how to implement that. But these things are all really important. It's an ecosystem of care that's bigger, but we want to get some of the building blocks, the really core building blocks right. And this conversation is really helpful. So Mike, what's our next question for people? Or have we worked through all the personal responsibility yet? These are workflow questions.
Not hearing any more comments on that one. So this one, I didn't know how far we were going to get, so I just put a whole bunch of questions on this slide to take us home. So wanted to talk about how screenings are performed today, and how that relates to who's interacting with the data, who's capturing the data, that sort of thing. And then once it's collected, if it wasn't somebody who would be doing an assessment after that, when do they see the results? Let's stick with those two.
At the risk of talking too much, I can get started. So in our current practice, in primary care, we screen at every annual well visit and upon ad hoc as identified, but generally every annual well visit. We see the results of the screening either immediately if the patient did it via the portal, or once it's been entered in, if it has to be entered in manually. The additional assessment comes upon if they've been referred to a guest assistance program. So for the interpartner violence and social isolation questions, they get referred to MSW, who does a further assessment upon that at that point. And for all of our other questions, they get referred on in primary care to the guest assistance program, which is a team of BSWs who support both inpatient, outpatient, basically everywhere. And they do a more in-depth assessment at that time. And I think I answered do you hand them off to someone else? And at both GAP and MSW, they refer into the community as needed.
Thank you.
So we'll call that a screen and institutional referral strategy. Does anybody have a different strategy in place? Are there folks out there who keep it within their practice with a community health worker as their person to follow up things? Or how have other people handled the messiness of doing this work in clinical care? So Alicia, you're the only one brave enough to talk about how, how you do it.
It might be true that I get lucky because I have, as a system, it is a more common process. I know that I've heard of other processes across the state where it's if they were referred to care management, or they tried to get people once a year, and it's based on like a registry again of like this is included as a gap in care. And so as the medical assistant or whomever is going through the gaps in care, they also use this as an indicator that has to be completed, and then refer patients into the community as they can. So I think it's where the screening is being done. I think it's attempted to being done with some sort of formula. Yeah.
So Alicia, do you know how much of the time is it tracked? Let me figure out how to ask this question correctly. Have we been able to track at Michigan Medicine how often the handoffs are missed or successfully made? Or is there no current way that we can do that?
So in our current dashboard, we have been working with quality analytics to see for the places, the internal at least referrals that have an actual referral mechanism. And this works better. So we track, did the referral happen within 2 business days of the appointment or 30 days before? Because in some situations we're sending out the portal requests up to 30 days before. And so that's, we can see if the referral happened. And then if the referral happened, was there a visit with the MSW or GAP as per their documentation within a month? And we're working on that within a month. But we've done some manual the manual review, and it looks like the guest assistance program usually gets outreach within 1 to 2 weeks. And the MSW referrals are generally done, or they're supposed to be done with an urgent referral for interpartner violence, which gets a same day, or like if it's done, if the information is entered in at like after hours, then like very early the next morning, that's the first thing that the team does with those referrals is they send a page along to the MSW team, who makes a call to that patient same day, so immediately. So ideally that happens very quickly. But we are trying to track at least the internal follow-up, and then ideally we're trying to figure out with the Find Help tool of can we see whether the loop was closed totally, and did that patient actually receive the services to which we refer them.
Okay. So you guys are trying to figure out systematically how to make that process more accountable, or figure out where there still may be gaps, and that's important.
Yeah, we implemented a slightly different process in our specialty care pilots, where we were proactively sending out the screening tool a month in advance, basically, and then sending out reminders via the portal to answer the questions, because we wanted to have lead time before the patient went to their pre-op appointment. That's where we were doing first, so that we could say, like what was going on, address basically any needs that might prevent this patient from getting their necessary surgery. And that has been, and then we centralized the place where all of those positive screens went. And that has resulted in a much more successful process than hoping that the medical assistant who roomed the patient also had time to enter in the information into my chart and pen the orders for any referrals, so that the provider is even aware during the visit that they have a patient who has some social needs that have already been identified.
Wow. I know we're almost at the end of the time. I guess, Mike, did you have anything else that we needed to throw at these folks? Or
the only thing I had was I wanted to just mention what our topic is for the next session, and we're going to be talking about social care snapshot and knowing what's going on with the patient based on this data that's been collected. What do we need to know? What don't we need to know? Like the problems list that we were talking about today is totally relevant for that conversation again.
Yeah. And so, folks, for the last few minutes, yell out at us. Is there anything that we're ignoring or not attending to in the Z code coding listing screening space that we didn't get to at this session that you'd love us to keep talking about, or that we need to bring back, or that we need to address? Because this has been incredibly valuable to get your feedback and to get your comments.
I don't know how relevant this is, but given that the World Health Organization has already released ICD-11, do we know how this is all going to impact when the US finally adopts ICD-11?
It'll be some time before we get to 11. We're falling further out of sync. I helped actually create ICD-11 when I was working with WHO a few years ago. And at the time, US had almost zero interest in how the thinking was in some of the adaptations or changes in ICD-11. So it'll be a while. I don't think we're gonna have to worry about that just yet. So don't worry about it yet. How's that?
My last parting question would be, do you know, is there something we can do to make it easier to evaluate Z codes and outcomes and closing the loop as we're documenting? Because I think it'd be a really helpful thing.
That's a great question. I wrote that down as a note to myself already too. Yeah, we'll be thinking about that. Thanks. Good, really good point.
I'll try to tie that into the social care snapshot and making use of the data for the next one. Thank you for that. With that, I think it's time for us to end, and everyone can have 2 minutes to get ready for their next meeting or to get to their work. Thank you, everybody, for joining. We really appreciate it. This was really helpful.
Thank you.
Thank you.
Send any comments our way anytime. But thanks.
Thank you.